The four main components of a GI assessment include inspection, auscultation, percussion, and palpation. Inspection of the abdomen includes noting any bulges or masses, any skin changes, and taking note of the shape and size of the abdomen. Auscultation includes listening in all four quadrants of the abdomen. Normal bowel sounds are considered 5 to 30 high-pitched gurgling sounds per minute. After listening, classify bowel sounds as normal, hypoactive, hyperactive, or absent. Note that you need to listen for 5 minutes before determining absent bowel sounds. Percussion should take place in all four quadrants. Tympany should be heard over the abdomen, and dullness should be heard over the liver and the spleen. Palpation should also take place in all four quadrants. Begin with light palpation, about 1 centimeter depth, and then increase to deep palpations, about 5 to 8 centimeters of depth. While doing this, ask the patient if they are feeling any pain. Some GI tests and screenings include endoscopy, colonoscopy, ERCP, and paracentesis. Upper GI endoscopy is a procedure in which a doctor uses an endoscope, a flexible tube with a camera, to see the lining of your upper GI tract. This is used to detect bleeding or changes in the lining of the small intestine. This procedure requires the patient to complete bowel prep. A colonoscopy is an outpatient procedure in which your large intestine is examined. During this procedure, the patient is lying on their left side. This procedure also requires the patient to complete bowel prep. Regular colorectal screenings begin at age 50. ERCP is a procedure that enables your physician to examine the pancreatic and bile ducts. A bendable lighted tube, called an endoscope, about the thickness of your index finger is placed through your mouth and into your stomach and the first part of the small intestines. Following this procedure, monitor patients closely for signs of respiratory or CNS depression, hypotension, oversedation, and vomiting. Paracentesis is a procedure to remove excess fluid from the abdominal cavity, which is the area between the abdominal wall and the spine. During this procedure, the client is positioned upright on the edge of the bed or in Fowler's position in the bed. Following the procedure, monitor for leakage or bleeding at the site and check vital signs, especially blood pressure and heart rate. Other diagnostic procedures include barium swallow, gastric analysis, endoscopic ultrasonography, CT scan, liver biopsy, stool specimens, urea breath test, liver and pancreas lab studies. The first of two inflammatory bowel diseases we will talk about is Crohn's disease. The pathophysiology of Crohn's disease is related to an abnormal immune reaction which causes inflammation in the bowel and typically involves all layers of the bowel. Clinical manifestations of Crohn's disease include skip lesions. These lesions can occur anywhere from the mouth to the anus. There's pain involved. There's also bloody diarrhea and an electrolyte imbalance with Crohn's disease. Complications of the disease include strictures, obstruction, abscesses, peritonitis, fistulas, malnutrition, and weight loss. Procedures used to diagnose Crohn's include double contrast barium enemas, transabdominal CT, MRI, and colonoscopy. The treatment includes drug therapy to induce and maintain remission. Some of these drugs are aminosalicylates, immune modulators, corticosteroids, and TNF blockers. Sometimes surgical removal of diseased bowel is reserved for complications. Nursing care of the Crohn's disease patient includes bowel rest for the patient, maintaining adequate nutrition, monitor intake and output, and colon cancer screenings and education. The second part of IBD that we wanted to talk about is ulcerative colitis. The pathophysiology of UC is an abnormal reaction which causes inflammation in the bowel. This inflammation typically starts in the rectum and spreads in a continuous pattern up the colon and only involves the mucosal layer of the bowel. Clinical manifestations include ulcerations in the colon lining, bloody diarrhea, abdominal pain, weight loss, electrolyte imbalance, and urgent bowel movements. One severe complication of UC is toxic megacolon. This is dilation of the colon that can cause infection, dehydration and shock, rupture, and peritonitis. In order to cure UC, removal of the colon is required. Nursing care includes resting the bowel, maintaining adequate nutrition, monitoring intake and output, colon cancer screening, and providing education. TPN is a hypertonic IV bolus solution. The purpose of TPN administration is to prevent or correct nutritional deficiencies and minimize the adverse effects of malnourishment. TPN contains complete nutrition, including calories and a high concentration of dextrose, lipids, essential fatty acids, protein, electrolytes, vitamins, and trace elements. TPN is administered through a central line or a single double lumen PICC line. Change tubing and solution bag every 24 hours or per the hospital's protocol. When administering TPN, keep dextrose 10% in water at the bedside in case the next bag of TPN is not available. This is to prevent hypoglycemia in the patient. An ostomy is a surgical opening from the inside of the body to the outside and can be located in various areas of the body. Ostomies can either be permanent or temporary. There are two main types of ostomies in the abdominal area, and they are ileostomies and colonostomies. An ileostomy is a surgical opening into the ileum to drain stool. A colostomy is a surgical opening in the large intestine to drain stool. Stomas should appear pink and moist. Signs of ischemia are pale pink or bluish purple color and dry appearance. Evaluate the stoma output. Output should be more liquid the closer the ostomy is to the proximal small intestine. Empty the ostomy bag when it is 1/4 to 1/2 full of drainage. Colorectal cancer is usually an adenocarcinoma that arises from the epithelial layer. Adenocarcinomas begin as a polyp and are benign in early stages. If left untreated, the polyp will grow and the risk of malignancy increases. CRC can metastasize through blood or lymph to the liver, lungs, brain, and bones. Spreading can occur as a result of peritoneal seeding during surgical resection of a tumor. Risk factors for colorectal cancer include African American descent, irritable bowel diseases such as Crohn's and UC, eating high-fat, low-fiber diet, being 50 years or older, and long-term smoking. Bodily functions often related to GI medications include bloody stool, nausea, vomiting, diarrhea, constipation, loss of appetite, and passing gas. The first class of GI medications are proton pump inhibitors. They are used for gastric and duodenal ulcers, erosive esophagitis, GERD, and conditions such as Zollinger-Ellison syndrome. Long-term use of these drugs can cause pneumonia. Be cautious about giving these medications to people at high risk for pneumonia, including clients who have COPD. In addition, be cautious about administering NSAIDs with PPIs because they can cause GI irritation. Administer PPIs once a day on an empty stomach so they'll work best. The ATI book recommends taking it in the morning before breakfast. Another class of GI medications are antacids. Antacids are used for treating people with peptic ulcer disease and GERD by promoting healing and relieving pain. They neutralize gastric acid by producing neutral salt and inactivating pepsin. Aluminum and calcium antacids can cause constipation, whereas magnesium-based antacids can cause diarrhea. Instruct clients to chew tablets thoroughly and then drink at least 8 ounces of water or milk. Teach clients to take all other medications at least an hour before or an hour after taking an antacid. In planning care for the patient with Crohn's disease, the nurse recognizes that a major difference between ulcerative colitis and Crohn's disease is that Crohn's disease A. frequently results in toxic megacolon, B. causes fewer nutritional deficiencies than ulcerative colitis, C. often recurs after surgery, whereas ulcerative colitis is curable with a colectomy, D. is manifested by rectal bleeding and anemia more often than ulcerative colitis is. The correct answer is C. Please pause the video and read the rationale for more information. Assessment findings suggested of peritonitis include A. Rebound tenderness, B. A soft distended abdomen, C. Dull intermittent abdominal pain, D. Shallow respirations with bradycardia, E. Observing that a patient is lying still. The correct answers are A and E. Please pause the video for further information. A patient with stage 1 colorectal cancer is scheduled for surgery. Patient teaching for this patient would include an explanation that A. Chemotherapy will begin after the patient recovers from the surgery, B. Both chemotherapy and radiation can be used as palliative treatments, C. Follow-up colonoscopies will be needed to ensure that the cancer does not recur, D. A wound, ostomy, and continence nurse will visit the patient to identify an abdominal site for the ostomy. The correct answer is C. Please pause the video for more information. A patient who has undergone an esophagectomy for esophageal cancer develops increasing pain, fever, and dyspnea when a full liquid diet is started postoperatively. The nurse recognizes that the symptoms are most indicative of A. An intolerance to the feedings, B. Extension of the tumor into the aorta, C. Leakage of fluids into the mediastinum, D. Esophageal perforation with fistula formation into the lung. The correct answer is C. Please pause the video for more information. When the nurse is assessing the health perception health maintenance pattern as related to GI function, an appropriate question to ask is A. What is your usual bowel elimination pattern? B. What percentage of your income is spent on food? C. Have you traveled to a foreign country in the last year? D. Do you often have diarrhea when you are under a lot of stress? The correct answer is C. Please pause the video for more information. During an examination of the abdomen, the nurse should A. Position the patient in the supine position with the bed flat and knees straight, B. Listen for bowel sounds in the epigastrum and all 4 quadrants for 2 minutes, C. Describe bowel sounds as absent if no sound is heard in a quadrant for 2 minutes, D. Use the following order of techniques: inspection, palpation, percussion, auscultation. The correct answer is B. Please pause the video for more information.